Okay. Now we gotta talk about some practical questions related to stem cell therapy.
Yes, sir.
So say if I come to your clinic, right now I have an ACL injury, but I think a common injury would be like an elbow thing. What's the most common injury you see?
I would say most common is the knee.
Knee.
Knee arthritis, wear and tear, meniscus, cartilage, old age kind of thing. That's
Okay.
number one.
Okay.
Not only here, even in US too. I would say if I see 10 patients, 5, 6 of them are there.
Okay.
Then comes the sports injuries for the ACLs, labrum, disc injuries. Disc is very common as well.
Okay.
Um,
What would be your procedure from start to finish? I'd also love to know kind of like a cost spectrum.
Sure, sure. So we'll go with the procedure first. Yeah. So in India and in US, as I said, the regulations allow us to do our own cells. And we're also comfortable doing our own cells, right? Like we don't want to use somebody
No,
else's.
but in all cases you begin with stem cell therapy?
No, no. It depends on your condition. So once we see any kind of tear, degeneration, cartilage loss, arthritis, then you advance to stem cells because stem cells have the potential to actually regenerate, thicken the tissue, right? When there is just inflammation, say like you come with the golfer's elbow, tennis elbow, and little sciatica, tendonitis. So these are called tendonitis, tendinosis. That means they're inflammation of the joints. You can have sprained shoulder. So these are not damaged yet, but they're either stretched or inflamed or an injury, right? You do not need stem cells there, or bone marrow stem cells, we call it. The reason is you're not trying to repair anything there. You want to uh, clean up the inflammation part. So we use blood derived platelets. It's called high concentration of platelets. You might have heard about PRP as
Yeah.
well. So PRP is a low concentration, but the high concentration platelets, we get it from the blood. So that's good enough. So not everyone that's needing a treatment needs stem cells from the bone marrow.
Got
So
it.
you can do platelet-rich plasmas, sometimes even prolotherapy, simple, saline injection into taking the adhesions and scar tissue away. That's also helpful.
So say
Yeah.
someone needs some help with stem cells for the arthritis or the ACL or rotator cuff tear.
Right, right.
What's your process as a doctor?
Yeah. So, as I said, we use that person's own stem cells, and the source of stem cells is that person's own bone marrow. So, with the bone marrow, we get stem cells, growth factors, and other good material with it. So, it's called bone marrow aspirate. So, that is what allowed by the government of India for us to aspirate. You cannot just take only stem cells and grow them, which we cannot do. So you're getting stem cells from your bone marrow. So per se, conversation's sake, I say BMAC, bone marrow aspirate concentrate, or stem cells, they're pretty much the same.
Okay.
So the process would be, say like you're coming, example, you have an injury, right? You're coming. So we determine you're a candidate. So I looked at your MRI, I examined you, and I feel like it's a partial tear. You have a great chance of healing and getting back on track. So you're a candidate. So the process would be me aspirating the cells from you first. So you come in, hydrate yourself. We prepare you for that thing, and you lie down on a table. There'll be a camera on top. And we numb it up here called iliac crest, this hip bone. A lot of people think it's the backbone. It's nothing to do with your spine at all. It's this hip bone. So we numb it up. Once we numb it, we put a small needle through the bone marrow. Sounds like painful, but it is not. It's
The needle goes through the bone?
through the bone. Yeah, even though it's a bone, it's like a really soft, spongy type structure right there.
Got it.
And that's the safest area. The reason why we go there, because there's no vital organs. You don't have blood vessels, you don't have nothing. It's the easiest, and that's the biggest reservoir in our body for stem cells. Yeah, we have stem cells in every bone, right? But it's hard to get to these bones. So you take it from there. It's people may worry about the name of it, but it's actually, I would say, a discomfort. Majority of the people say like, oh, that's it.
So you're saying there's almost no pain, but there's little discomfort.
Discomfort, yeah. Just like, when you put a needle. discomfort, but that's all. There's no major pain or anything.
Could you compare it to a run-of-the-mill injection?
Yeah, so like if you get a flu shot, for example, you feel like a little discomfort. It's the same thing. Here, you're also getting the numbing. So in the flu shot, you're not getting numbing, you're just getting the shot. Here, you're getting the numbing first. So a lot of people can't even tell, even if somebody says like, oh, I feel a little pressure. Most of the people like pressure, that's all. So put the needle in there, and under the camera, you get to see it. We aspirate the bone marrow. It's called bone marrow concentrate. So we aspirate that thing.
It's liquidy?
It's kind of a semi-liquid. If you look at the blood is pinkish, right? So the bone marrow is more maroon. So
Darker
it's a
blood.
little bit darker blood. It's much thicker because it's got all the ingredients we talked about compared to a blood. So it looks, I know you're getting scared, but don't not worry. It's not that bad at all. It's more graphic when we talk about it. So we take a good volume of the cells. Sometimes if I'm doing multiple joints, for example, if I'm doing this knee, I may take it from both sides. Or if I'm doing just one side, I'll get enough cells with a 60, 70 cc volume. We get that from bone marrow. So once it's done, all you will get is like a little bandage, that's it. There's no suturing because we didn't cut it. It's just a needle. Everything closes in and the patient gets up and just go walk around, eat something, drink some fluids, kind of move around a little bit. So we'll have some downtime, like 2 to 3 hours. In that time, what we do is we separate the bone marrow concentrate. And as per the rules, we can separate it, not manipulate the cells. Government of India says like you can separate it. So we separate the cells and extract the cellular portion only. So even the marrow is this much, the cellular portion actually maybe, for example, if I'm doing your ACL treatment, I may get like 3 to 4 cc of the actual cell portion. So we get that thing. Then I put you under camera again, same day. You got to do the same day, right? So you're under the camera. We put some ultrasound guidance. We put some fluoroscopy guidance. So I'm able to visualize your torn area. So we numb it up a little bit on the, so you don't feel, you don't complain, you don't scream. So you're comfortable. You can watch it on TV as well. So with small needles, and we advance into the torn area so we can visualize what's going on. We confirm the placement because the ACL could be a proximal tear, a distal tear, a mid-portion tear. And the ACL has 2 bundles. So it's like 2 bundles. So anterior posterior bundle. The advantage of doing this procedure over surgery is when you do surgery cannot get your 2 bundles back. It will be only like 1 graft. And also your ACL has proprioceptors. That means that will tell you, hey, my balance and all those. When you do surgery, you lose that. That's the reason you see most of the ACL surgically repaired, almost a higher percentage, almost 50% re-tear within like 2 to 3 year period. You see all these athletes, most of our football guys. But unfortunately, if somebody has a huge tear, they have to go for surgery. But smaller tears like you don't need to go for surgery. You can repair it. So with the visualization, with the camera, so we go place the cells in the knee. So then we immobilize with not the big immobilizer, just the brace, the ACL brace with a little bit of, hinge right here. And that one day you do the crutches and you walk out without weight bearing or partial weight bearing. So you go home.
But does the injection hurt?
No, it's all numbed up, right? So you don't feel it. And the needle size is 25 gauge. 25 gauge is like your diabetic needle. So it's discomfort, like something poking, but not like pain. Pain is there when you cut everything, right? We're not cutting anything. We're just advancing, precisely going into the areas, visualizing it, placing the high concentration of cells, and then slightly immobilizing, sending you home. Then I bring you back the next day. The reason I bring you back the next day is, so we put the seeds in there, right? Then I need to water that. I need to fertilize that. So I need to activate the cells. So the next day we draw your blood. And with the blood, I get all these growth factors, the high concentration of platelet mix in there. So that we put it around that. We don't go in the graft or in the tear. We put it around so that your knee absorbs all this material. So that activates the stem cell growth or bone marrow aspirate growth, basically. Then you go home, 1 to 2 days, we tell you, hey, don't put too much weight on it. Use the crutches as needed. Wear the brace. Just get in the car, get out, and do minimal things. After 5 days, we will start physical therapy, the exercise program. Not high intensity. You're going to start with your own body weight, like slow intensity with your body weight, isometrics, we call it. Kind of you're trying to build the VMO, we call it, the quads, the things that support your knee, more specific knee exercises. You start doing it either in the office or at home, wherever. So 1 week you do that, second week you bump up, you go a little bit more weight, third week you go up. So as come to a month and a half, you start feeling the strength is coming back and your confidence coming back, the stability coming back, and the pain getting back. Then you feel like, okay, I can get into, if you're a runner, you go into running, but it's too early for us to send you running after a month of this, right? So we start slowly. We may let you jog a little bit, do an elliptical. So we graded advance it. So then I follow up again, or my team will follow up again. At that point, we do boost it one more time with a little bit more of the platelet mix.
The fertilizer.
Fertilizer again. Because by the time we expect you're reaching the second stage of more functional. So you're going to do more functional. After that point is when I'll kind of let you loose. Kind of, hey, examine, everything looks good, tight. Okay, let's go a little bit more movements. If you have an ACL tear, you're not going to go to sports in 2 months. In 3 months, you can go back to sports.
3 months after the stem cell.
We're talking high level sports, like, but the recreational little things, you can do it. So exercises, you do it. Workouts, you do it. Gym, you do it. Only thing you don't do it is cutting, planting, jumping. Those you don't do it for 2 months. Changing direction that risks a re-injury, we will not do it. Most of the athletes, like that we treat, or non-athletes, around 3 months. Sometimes I may get a repeat MRI if the demand is more. If somebody needs to go back quickly, I'll look at it, looking good, we let you go. Sometimes I may not get an MRI that soon. I may get an MRI like 5-6 months later. With non-athlete, hey, I'm doing good. Hey, just get back, incorporate into your workouts. Okay. We do that thing.
Couple of questions.
Mm-hmm.
Firstly, we just spoke about knees in this case, but say if someone's got a shoulder injury, I don't know what else, spine maybe?
Yeah.
Similar process.
Yeah, so same thing. For example, spine is a little different, but I'll tell you shoulder. Shoulder most commonly is like the rotator cuff tear.
Yeah.
Like, not able to lift it, sleeping. People can do this, but lifting, that means you have torn the rotator cuff. There's also something called a labrum, which is like that little layer, the cushion layer. You can tear that thing. It could be degeneration, wear and tear, working out in the gym, or like just sometimes even diabetic people can have it without any injury, or sports people also can have it. So anybody can have it. So that's one of the common thing. Similar process, right? So we aspirate the stem cells and image guided and inject precisely into those areas, rest it, slowly incorporate them back into their regular lives, basically.
Probably the timelines are slightly different.
Yeah. So for example, the knees and the shoulders, to a certain degree of hips, similar. Whereas when it comes to, there is a condition called AVN. You might have heard about it, called avascular necrosis of the hip. These days, since the COVID has come, in India, it has become like an epidemic. The reason is a lot of people during COVID were given steroid medications, to save some lives, right? Like everybody had like a Delta wave and all that. But steroid caused damage in the bone. So the blood supply in the bone disintegrates. So then the hip starts collapsing. We see that in younger people.
Hip starts collapsing?
Yeah. So if the hip is like a round, and imagine you lose the blood supply in there. So there is no support of structure, starts collapsing. So it starts with stage 1, 2, 3. When it comes to 4, it collapses. That's we're seeing a lot because of the mostly COVID. So that's a different kind of procedure. That procedure is, for example, in your case, we're injecting the connective tissue, soft tissue in the joint. But if it's AVN, we have to go in the bone, not in the joint. So we have to drill into the bone, put the cells in there, create that new blood supply again. So that thing requires like 1 night of hospitalization or 1 night of stay. So that's a little different recovery on that
Gotcha.
one. Same thing with the disc. Disc is also as an outpatient. I would say 99% of the hips, shoulders, knees, ankles are all outpatient procedures.
Okay.
There is a one case like this, we may have to keep overnight and observe the patient.
And in all those 99% cases, the pain levels are roughly bearable.
Very tolerable, very tolerable. To be honest, like maybe disc may be a little bit more painful, but depending on the procedure, we kind of help that aspect as well, right? Like, for example, I'm anticipating pain from your disc procedure. We will give you pain medication to get you through that thing during that day. Most of the pains, seriously, if they have it, 24 hours. On the second day onwards, what happens is when we inject the bone marrow cells, we are creating inflammation. So I'm creating a healing response. So it's not like putting a medicine in there, right? So what it's doing, it's actually creating more of a swelling and inflammation before it starts healing. A lot of that heavy swelling inflammation lasts like 24 hours, and our body starts absorbing again. And by next day, they're feeling like, okay, it's not as bad. 1 night was uncomfortable. We give a couple pain medications. They expect that thing. They sleep, get through it. Next day, they feel good. Some people, even drive themselves.
Yeah.
Majority of these are outpatient, minimally painful, and never significant pain or anything like that.
Are there cases where the person's body doesn't respond to stem cell therapy for whatever reason?
It's unlikely. The reason is like the way we live, the way we are functioning, the way we are healing is through our stem cells only. There may be a condition where you have stem cell diseases, like bone marrow diseases, very rare conditions, and they have defective stem cells, and those are the people that require bone marrow transplantations. Those cases may be, but as a healthy individual that's functioning, you will respond. The response does not depend on whether you have stem cells or not. The response depends on, are you a candidate? That means, are you coming stage 4 or stage 2? If you're a stage 4, you're not a candidate. We will not do it. There's no point. You're not going to get better. You need surgery. When it's stage 3, 2, 1, yes, you are a candidate. So that dictates who is a candidate, who's not a candidate. Not like whether we have cells. We all have cells. Our body lives. Even a 98-year-old person will have enough cells to help his own body. 15-year-old person will have it. So age group wise, we all have cells as long as we're living, and our cells are good enough to heal ourselves.
Costs, sir. Cost spectrum.
Costs vary depending on if we do a platelet procedures, much cheaper. Generally, I don't know, 20, 30,000, 40,000, could be 50,000, depending on the areas. The stem cells, newer technology, and so slightly little on the higher side. But compared to surgeries, maybe if surgeries are, I don't know, 3-4 lakhs, whatever, these could be 2-3 lakhs or less. So much less than surgeries. But we are anticipating as we go in, because some of these, I would say, kits extraction, we still bring from US. So the manufacturing process is not here. So it gets a little expensive, part of it, the centrifuges and all those. But once, I would say, as we have more and more acceptance and I think the cost will go even significantly. For example, in US, the surgery cost is almost 10-20 times more than a stem cell cost. If stem cell procedure, example, if you're doing a knee or shoulder, on an average cost $6,000 to $7,000, a knee replacement surgery costs $70,000 to $80,000. So here, hopefully, it will happen of that nature, but presently, it's still not too cheap either.
Yeah, it's like 60-70% of a surgery's
surgical cost, I would say.
Okay.
And some of the higher, like bigger corporate hospitals, may be even more expensive.
Yeah. The overarching point here is, I think there's a big price that one pays for surgery.
Yeah.
which you only understand after you go through a surgery.
Right.
It's always better to try other means before you go in for the surgery. That's my opinion.
No, absolutely.
And of course, in saying that, if it's completely torn, if it's completely ruptured, you have to go for a surgery anyway.
Yeah.
But try exploring your options before you.
Exactly. So there are multiple advantages for that, right? So imagine like you're trying to keep your own ligament. So biologically you're intact. So you have certain ways, body has certain ways of moving, certain ways of sensing. So you're all there. Imagine you have a metal, you have an implant in there. So you have an artificial.
Yeah.
It may be good for a while. What if it wears out? Then what do you do later? So somebody who needs it needs it. There's nothing like nobody needs. People need surgeries for sure, but not everyone needs surgeries. Majority of them can benefit with these interventions.
Okay. Hey, if you enjoyed today's clip, make sure you check out all the other clips we've uploaded on this channel. You'll find a clip related to almost every single topic as long as you're willing to search for it.